try to, or I guess holy.
Sorry, Lucy. Yeah.
It's all good. I guess what I want to impart is just like principles of like how to read a chest x-ray, and like learning about that through a case, which is way better than just didactic. So let's start. Okay. So this, I guess this is the, oops, the PDF you guys were given as well. So 77-year-old male with chronic shortness of breath, and you get this chest x-ray. So I'm gonna ask one of you guys to describe it just in a bit, because I think really that's like the only way to get good at reading x-rays is just practice, and saying it out loud is way more difficult than like seeing what the abnormality is. Yeah, like the description is, it's like a fine art to capture accurately. So before that, I'll just say my approach. I usually like, I start from like the airway and then the lungs, and then you want to compare this. Symmetry is basically your best friend in radiology. So like this area should look like this area, and then the middle should look like the middle, and then lower to lower, and it should be pretty uniform throughout the lung field. And then I look at the heart, or I guess mediastinum, and look if the contour is like normal in size, and if it's being like shadowed anywhere. And then I look at the, oh, actually before the heart, I also look at the pleura. I just follow it along like this. You guys can see my mouse, right?
Yes, we can.
Okay, cool. And then this way, yeah, and then I do the heart, and then bones and upper abdomen in the end. And essentially, since we just have black and white, most things that you see, or I guess all of them, like it's either too white or too black. So too opaque or too lucent. And I think it's good style to talk about things on radiographs in terms of opacities and lucencies as opposed to consolidation, because you don't really know if something is a consolidation or not. Like a mass is not a consolidation. A consolidation is like something like filling up the alveoli, and like a mass can, it doesn't really fill the alveoli. So it's just like best to stick to opacity or lucency. And then in terms of the location, if you don't have a lateral radiograph, you don't really know like where the upper lobe starts and the lower lobe start, because they look, it's like this, right? So if you have something here, you might be tempted to think that it's in the upper lobe, but it's not. It's actually in the lower lobe. So usually, like we say, upper, middle, and lower lung zones, kind of in thirds. If you have a lateral, then you can be more definitive about which lobe it's in, but I think it's just easiest to stick to the zones. And then, oh yeah, and the last thing I do on x-rays is I check my blind spots, or I guess everyone's blind spots. This is like the spots people most commonly miss things. So really often we forget that there's lung behind the diaphragm, because, oops, this is not, let me see. These pictures aren't great, but since the diaphragm is like, goes like this, if you can imagine, some of the lung is actually behind the diaphragm, like the posterior lung is behind the diaphragm. If we zoomed in close, we would see that there's like lung markings here and here as well. And a lot of things get missed in these areas, and then also behind the heart. And then pneumothoraces, really small ones up here and up here. Yeah. And then in these two corners, effusions. So these are kind of the check areas I do after every study, basically. So who wants to practice taking this case? I'll put a normal as a reference, and then just practice describing whatever you're seeing. Okay, maybe I'll just pick on some for the love of God.
Well, I know. I mean, I know the answers. I feel like it wouldn't be fair if I kind of did it, but I can take a stab at it just from memory, sort of. So looking at the scan, yeah, there's definitely increased diffuse opacity throughout both lung fields compared to the normal. They're sort of linear opacities as opposed to rounded. I also notice the cardiac silhouette seems not enlarged, normal. There's no blunting of the costophrenic angles. The aortic knob looks slightly enlarged to me, and then there's also kind of linear opacities on the superior portion of the diaphragm by the lateral on both sides.
Okay, very nice, very nice. I would say multifocal as opposed to diffuse, just because I think it's a bit more specific. Because like diffuse, you might like imply that it's like everywhere uniformly, like pulmonary edema, for example. But like I think multifocal captures that there's like multiple lesions better. Yeah, the shape description was also accurate. Another thing that you could add is that they're very dense, because this I would never expect a pneumonia, for example, to be this dense, like this edge here. It's almost as dense as the bone. So that's also helpful to include because it will build towards our final differential. Yeah, so and you mentioned that this is probably age related. It's tortuous and just looks funny. So very good. What's the next? Oh, we do have a lateral, but this is a really bad picture actually. I think whoops. Try to, oh, I got a better picture from Radiopedia. And the reason this is helpful is because now we can actually localize it better. Actually, maybe not. Okay, I think that's I'm spoiling a little bit. I'm jumping ahead. Okay. So yes, we saw abnormalities. It was too white. The shape, I'll probably call it irregular nodular with sharp borders. And here are arrows pointing at the abnormalities here. And then, yeah, you can see that it's also kind of like outlining the medial lungs here and here. And it's on the diaphragms as well. Okay. What did I want to tell you? Oh, yes. Okay. So the concept of zones, don't pay attention to the numbers. This is like not really something that we use, but in general, we do localize things if they're lung, like parenchymal versus pleural versus chest wall versus mediastinal. And the reason is that because it has a different differential diagnostic pathway depending on the location. So if there was a perihilar opacity, it's probably lymph nodes, or it could be like pulmonary, but immediately in the hyla, in the most medial aspect of the lung. But if I wouldn't really expect like lymph nodes up here, you know what I mean? And then in the mediastinum, there's also a differential diagnosis of like masses. Like you can have lymphoma, thymic tumor, germ cell tumor, forgetting what else. Oh, like thyroid, like goiter, and you can also have an aneurysm that makes it look widened. So that's why we try to be as accurate as and as specific as we can. Yeah, okay. Did you identify all of the abnormalities? Okay. David, how effective do you think your approach was?
Yeah, I mean, I thought it was all right. I guess, I mean, I missed a few of them, even though I've looked at this case before. I guess I always struggle with, and probably a lot of our participants do too, like approaching things in a systematic way, right? Like I tend to kind of look at the scan overall and compare it to like the gestalt that I have so far of what's normal, but I struggle with having a step-by-step systematic approach to things.
Okay. You did find everything though, and like you did mention the rest of the exam too. Okay. But I mean, like practice makes perfect. The more you look at, the more like efficient you'll be, I guess, and the more you'll be able to look at it all together. Okay, so does anybody want to take a stab at the location of the abnormalities, or like is it because when we go, I guess okay, so the X-ray beam on the way to the film, when it goes through your body, like first it goes to the chest wall, then pleura, then lung, then pleura. So these can, I guess, be arising from any of these structures. The lateral does help us, but the reason I want to know where it's coming from is, again, it helps us narrow down the differential. So where do you guys think that the lesions are located?
I can try. I'm looking at the lateral view, and it is hard to like see things. So I guess the lateral view is where we can localize things better. And I believe I see a lot of like some of the opacities around like the frontal pleura or anterior pleura.
Here? Yeah. Here, and then there's some here as well. Okay, so you think it's pleural?
Yeah.
Okay, and you're correct. I think like hypothetically, like it could be parenchymal too, but it's just like this case is basically pathognomonic, so I know it's not parenchymal. But if it was like immediately subpleural, that's plausible. But yeah, like these are pleural. And I think, yeah, I guess like the learning point here is that we can't really localize anything for sure with just a PA. You need two planes in order to triangulate where something is, because like this, technically, like this could be anywhere in the patient's body until we look at the lateral and we see that it's on the pleura. Okay. Whoa. Jumping around here. So, yep, pleura localization. I don't remember if you mentioned it, David, that they were pleural, but anyways, we figured it out with the lateral. Okay. So what is on your differential diagnosis? Somebody else answer this question.
I think the only pleural related like opacity thing I remember is like mesenthelioma.
Okay,
Maybe.
yeah, very nice. Yeah. Okay, so the most common thing is like mesothelioma is essentially like when there's like malignant transformation of pleural plaques. Like these are calcified pleural plaques. It's like pathognomonic for prior asbestos exposure. And yeah, like they can transform into mesothelioma, which is the malignant version. And with that, you see more changes. Like you'll see the lung shrinking. There's like a thick rind of like pleura, and it almost like contracts or like it's not pliable or something. And the lung basically shrinks and shrinks. So before it gets to that stage, when it's simply a calcified pleural plaque, it's like that's just what it is, and it's essentially benign. I'll show you what mesothelioma looks like. Um, oh yeah, right here. So this is malignant, and usually they have effusions too. Like this is a really great example because they have the calcified pleural plaques. You can't really see the thickening too well, but there is a malignant pleural effusion. And for example, in this picture, you can see that the lung is shrunken compared to the other one. Okay. Oh yes. So they're kind of explaining a concept called the incomplete border sign, which is essentially a function of like the X-ray beam, because if you're shooting the X-ray from here, it comes from a single source, right? But the film is big, so like all the rays are angled. So this 1, 2, 3 corresponds with these three beams, 1, 2, 3. When you have a nice interface between like the aerated lung and the lesion, it's gonna look sharp, like here. And then like beam number 3, it doesn't really have an interface with the lung, so it doesn't have a border on that side. And they use this because like if it was like in the middle of the lung, like here, it would be perfectly circumscribed, but it's not. So that's something that we sometimes use to say if something is extrapulmonary. Yeah, and then here you see the example with like the plaque is on this side, it's really sharp, and here you can't really draw with a pencil around it. Yeah, so it's posterior to the chest wall and anterior to the lungs, and it has to be in the pleural space. And this is what it looks like on CT. So it's really coarsely calcified, like even thicker than the cortex of the bones. So that's why it really jumps out on the X-ray, and that's why if like the density is if it's really dense like this, it narrows your differential a lot. Like even if it was a pulmonary lesion, there's not that many things in the lungs that calcify. So it's really helpful to like compare to the bones to see if it's like soft tissue or if there's calcifications in there. And this is what it looks like on coronal views of the CT and sagittal. How would you characterize these abnormalities? I'm not really sure how we would answer this question. Okay, does anyone know why the CT was ordered or like want to take a stab or I guess you can answer any of these questions. You have enough information. Okay. All right. Jeffrey, are you here? Maybe not. Selena.
Oh,
Okay.
sorry.
You guys are
I am here.
No, it's all good. All right. Why do you think the CT was ordered?
I'm thinking just to sort of better localize where the plaques are versus on a plain film.
Okay. I guess this also ties into the second. Oh, did I close it? No. It ties into the second question, which is, does having CT change your localization? Does it?
I mean, I guess it doesn't. We kind of localize it to the pleural space using just the lateral, right? So it doesn't seem to change it, but maybe it just confirms it. Like it just, because there was a bit of ambiguity when we were talking about the lateral.
I guess that's true. Yeah, because the like for this case specifically, this appearance is so classic. Like there's literally a sign called like polyleaf sign. Like experienced radiologists, I don't think would really need a CT to confirm this because it's so characteristic. But you're right, like it does help for confirmation, because like when I was looking at this lateral x-ray, like you see how on the frontal you have a huge plaque here, on the lateral it's here, so it also kind of looks parenchymal for some reason. I think I don't know if it's like, yeah, this confuses me a little bit, because like here I think it looks like it's either like the anterior or posterior pleura, and here it's not really at the pleura. I'm not really sure how to explain this, to be honest with you. So like this is confusing. Like maybe that's why they ordered the CT. The quality of the x-rays from the PDF, like the lateral, wasn't great, so maybe that's why. Maybe, yeah, I'm not sure, but anyways.
Can I ask a question just for clarification? So what is it about the lateral scan that makes you say the quality isn't great? Like what is it about the scan that kind of impairs your interpretation?
It's so pixelated.
Oh, so just literally the image. Okay, the image.
Yeah, it's like really pixelated. It's like hard to see the plaques. Like it doesn't look as clean as this guy. But anyways, okay, I also suspect they might have ordered the CT because like the presence of plaques like this implies that somebody had asbestos exposure, which significantly increases your risk of not just mesothelioma, but also lung cancer. So maybe they were looking for these like suspicious features, like I mentioned, like the circumferential thickening or like volume loss or abnormal nodularity. Maybe they were looking for that. I'm not sure. The other thing that you can get with asbestos exposure is actual parenchymal lung disease, which is like actually called asbestosis. Like the plaques are not asbestosis, that's just asbestos associated pleural disease, but maybe they're looking for the lung disease. Yeah, and then I think, yeah, so other components of history would be prior asbestos exposure, because these actually do have a short differential diagnosis, which essentially like the body really likes to calcify things with like chronic inflammation. So a chronic infection could give you eventual plaques like this. Prior trauma can give you plaques like this. What else? A prior hematoma can give you this as well, but usually that's not bilateral. Usually that's only on one side. So like both that it favors the diaphragm, which is also something that asbestos likes to do. I think it's because it's like the asbestos fibers are super heavy and like they sink down. I don't know if that's just something I made up or that's true. So that's why they really like the diaphragmatic pleura, and the constant, it just like, it irritates the pleura, and the chronic inflammation induces this hyperplastic reaction that eventually calcifies. Yeah, and I think, oh, here, pleural calcifications can occur following hemothorax, infection, inflammation, trauma, surgery, radiation therapy. Yeah, so the clinical history really helps to confirm it's asbestos as well. Okay, so we have teaching points here to like wrap it up. I'll just go over them briefly. So like we mentioned, the density of the opacity does help us, because when something has calcifications or ossification, if it's bone, then it takes your differential diagnosis, it narrows it down. And then some things that are helpful to know if something is plural in origin is obviously like if you have both PA and lateral film, you can triangulate it that way, but there's also some other signs, like indirect ones, like the incomplete border sign we can use to kind of like deduce something is extra pulmonary. And then we covered asbestos related pleural disease. So it's usually bilateral, favors the dome of the diaphragm. It has like a little bit of like an apical-basal gradient. I assume because the fibers are heavy, but I'm not sure. But that's like a very typical look for asbestos. And then, yeah, the differential, especially if it's unilateral, you can be thinking about like prior infection, hemorrhage, trauma, surgery, radiation. Let me see if I missed any learning points. Oh yeah, and then the other thing is that try to like describe the lesion as well as you can, because often that will lead you to the diagnosis. If you say something is like angular, sharply marginated, very dense, like if I was describing that to my co-resident, they would know that I'm talking about asbestos, because it's basically like, it's like a cookie crumb trail to the diagnosis. Okay, does anyone have any questions?
I guess I'm wondering, like, so how you talked about the past asbestos exposure, right? How important is that clinical picture to you, like in this specific scenario of making the call? And do you ever kind of, if a report is not giving you a lot of information, do you ever kind of follow up and reach out and try and get more information, or is that like not possible?
No, we just presume it's like, we say like calcified pleural plaques, most likely on the basis of prior asbestos exposure. It's just so typical, so pathognomonic that even, yeah, like it's just I guess it depends on how many there are. If it was like one isolated plaque somewhere, then it could be any of the other differential we talked about. But when it's this diffuse, it's essentially diagnostic. And if the patient doesn't think they have asbestos exposure, they probably did. Like it's that classic. Yeah. Any other questions, guys? It doesn't have to be about like this case. You could ask questions about radiology in general or any other topic that you would like to ask.
I just had a quick question. Were there any like resources you recommend for just like getting good at like reading like just basic plain chest radiographs?
I think, let me see, I think there's radiology, no, it's called, I'm trying to remember what it's called. There's a guy on, he makes really good videos. I know everybody recommends the Felson's chest x-ray book. I personally don't like it. I thought it was like too basic. Is it navigating? I think it's him. Let me just see. Oh my God. Yeah, I think, yeah. Look up navigating radiology. He should, I think he has a chest x-ray resource. The other one that's like really comprehensive, I remember looking at, I thought it was too detailed myself, but it was still good. It was the chest x-ray approach by Strong Medicine. He makes a lot of other videos too, non-radiology, but like this guy. Medicine X-ray. Yeah, and this guy. And I think, yeah, try to get more experience under your belt, because like for me, it's easy to see an abnormality because I already have like a reference standard in my head because I've looked at hundreds of x-rays. So like that's like the best thing to do to like build your sense of normal and abnormal, because otherwise it's very hard to detect an abnormality if you don't have a normal to compare it to. Yeah, so like do your best on all your rotations just to take a stab at reading it yourself, because you will improve. And like as long as you keep doing the systemic approach again and again, like you'll get better and better. And it's a really useful skill to have, whether or not you go into radiology. Like on emerge, it's super useful. Internal medicine, surgery, like people get chest x-rays all the time in the hospital, so it's really nice to be able to read it yourself. So I highly recommend just like to practice like describing it, because that's the hardest part. Yeah. Any other questions? Okay, cool.
Okay, well, yeah, thank you so much, Lucy, for hosting the event and for walking us through the case. Really appreciate your involvement, and yeah, it was really helpful.
My pleasure. If you guys have any questions, you can just email me. My email is my name dot my last name at medportal.ca. Or David can give it to you guys.
Perfect. Okay, thank you so much, and thank you to all who came out. Take care, and we hope to see you next month. Okay, take care, Lucy.
Bye, guys.